Bismillahir Rahmanir Rahim. Our lecture today about the musculoskeletal infections, bone infections. We start by the histology of the bone. You see here the articular cartilage and the epiphyseal growth plate, and here the secondary epiphyseal center or thigh center, and here the diaphysis, and here the metaphysis, and here there is blood supply to the area, and how there is a circle or network of the highly vascular area with the primitive cells in growth. Here you can see the bone, also the epiphysis and the blood supply of the epiphyseal centers, and here the blood vessel where it passes through the epiphyseal plate, and here the nutrient artery. For each bone we have one or more nutrient arteries. Then we come to the general aspect of infection in general. Infection can define as a condition in which the pathogen organism multiply and spread within the body tissues. And this usually gives rise to an acute or chronic inflammatory reactions, which is the body ways of combating the invader and destroying them, like a battle between the invader or microorganism and the host, or at least immobilizing them and confining them to a single area. The bone infection differs from the soft tissue infection since the bone consists of the collection of rigid compartments and is more susceptible than the soft tissue to vascular damage and cell death because of its compatibility. So from building up of pressure in the acute inflammation, this is called bone necrosis. Unless it is rapidly suppressed, the bone infection will inevitably lead to the necrosis of the bone. And the host susceptibility to the infections is increased by local factor and systemic factor. Local factor like trauma, scar tissues, poor circulation, diminished sensitivity, and chronic bone or joint disease, and the presence of the foreign bodies. While systemic factors which make the host more sensitive to infections, including malnutrition, general ill health, debilitated, and diabetes, rheumatoid disease, corticosteroid dependent or administration, and all forms of immunosuppressive therapies, either acquired and also immunosuppressive disease, whether acquired or induced. Bacterial colonization and resistance to the antibiotic is enhanced by the ability of certain microorganisms, including staphylococci, to adhere to a vascular bone surface and foreign implant, protect themselves by a defense mechanism by forming of a protein polysaccharide film, which is called glycocalyx. And this glycocalyx, which help these microorganisms to become inert for a time and then reactivated when there is a foreign material like an implant or dead bone. We have a group of factors that work as a general factors for make the host more susceptible to the infections. Okay. Here are multiple pictures to show the evidence of local factors that make the infection to spread from area to the bone. And here we starting by discussion of acute hematogenous osteomyelitis. Osteomyelitis means infection of the bone, and including the cortical bone and medulla. Etiology: acute hematogenous osteomyelitis is mainly a disease of children. When it occurs in adults, usually it is because of impaired resistance. If we have an adult with osteomyelitis, definitely there is something wrong in his immune system. Trauma may be determined the site of the infection, possibly by causing a small hematoma or fluid collection in the bone in a patient with a concurrent bacteremia, that is, make the area susceptible or make the area liable for invading by microorganisms and to cultivate and multiply in this area. The causal organism in both adults and children are usually Staphylococcus aureus. It's found in about 70% of the cases, and less often one of the other gram-positive cocci like Streptococcus pyogenes, Streptococcus pneumoniae, and in children between 1 to 4 years we have gram-negative Haemophilus influenzae. And it is a fairly common cause, but due to introduction of the of immunization nowadays, it is reduced. Okay. Other organism, Kenji has taken the role as a causative organism in children nowadays. Other gram-negative organisms, Escherichia coli, Pseudomonas aeruginosa, Proteus mirabilis, and anaerobic bacteroid fragilis, as occasionally cause acute bone infections. And patients with sickle cell disease are prone to infection by salmonella. Unusual organisms are more likely to be found in heroin dependent or those addicted as opportunistic pathogens in patients with compromised immune system. Here, there is pathological pictures of the acute hematogenous osteomyelitis or classic picture of inflammations. Okay. The pathogenesis of osteomyelitis in children, the infection usually started in the vascular metaphysis of the lower bones, and most often in the proximal tibia and distal femur, proximal end of the femur, and so on. A predilection for this site traditionally has been attributed to the peculiar arrangement of the blood vessel in that areas. The non-anastomotic terminal branches of the nutrient arteries twist back in the Herben loops before entering the large network of sinusoidal veins, and this relative vascular status and consequent lowered oxygen tension are believed to favor bacterial colonizations. And in fact, in whom there are still anastomosis between the metaphyseal and epiphyseal blood vessels, infection can also reach the epiphysis. And here we have this picture. There is anastomosis, okay, so that the infection can spread. While in those older than this, there's a barrier in between the epiphysis and the metaphysis. Here the site of infections, and here the arteries, in the arteries, and here in the sinusoid. This arrangement of blood supply make this area vulnerable to that. We come to the pathology of acute osteomyelitis. Acute hematogenous osteomyelitis shows a classic picture or progression of infection and inflammation, starting by inflammations, then suppurations, and then bone necrosis, then reactive new bone formation and resolution and healing, or intertubal porosity. However, the pathological pictures varies considerably depending on the patient age, site of infections, and virulence of organism and the host response. Inflammation. Acute inflammatory process or reactions occurs with vascular congestion, oxidation of the fluid, and infiltration by polymorph nuclear leukocyte, and pain, obstruction to the blood flow, and intravascular thrombosis. Separation. By the second or third day, pus will be formed within the bone and forces its way along the Volkmann canals to the surface, where it is protrude to supraosteal space. And this is much more evident in children because of relatively loose attachment of the periosteum to the bone than in adults. From the supraosteal abscess, pus can spread along the shaft to re-enter in the bone at another site or another level and burst into the surrounding soft tissue maybe and developing physical act as a barrier and then developing an abscess outside. The developing physis act as a barrier, as we mentioned, to direct spread towards the epiphysis. But where the metaphysis is partially intracapsular, example in the head, where the head and part of the neck, including in the capsule of the inside the capsule joint, the shoulder and elbow, pus may be discharged through the periosteum into the joint, and both of them, osteomyelitis and septic arthritis, occurs at the same time. Bone necrosis is the third stage where the rising intraosseous pressure, vascular status, small vessel will thrombose, and periosseous filling increasingly compromise the blood supply. By the end of a week, there is usually microscopic evidence of bone death. And bacterial toxin and leukocyte enzyme also may play a role in this advancing tissue disruptions. With the gradual ingrowth of the granulation tissues, the boundary between the living and devitalized bone become defined. Pieces of dead bone may be separated as a sequester, varying in size and merged because of too large necrotic segment of the cortex in neglected cases. The active new bone formations, another features of advancing acute osteomyelitis is new bone formations. After the necrotic bone, the defense mechanism of the bone reacts in the form of the new bone formations. Initially, the area around the infected zone is porotic, probably due to the hyperemia and osteoclastic activity. But if the pus is not released, either spontaneously or by surgical decompression, a new bone starts forming a viable surface in the bone and from the deep layer of the striate periosteum. This is typical of biogenic infections, and fine streak of subperiosteal new bone formation usually become apparent on the X-ray, but at the end of the second week. And with the time, this new bone thickens to form a casement or involucrum, what's called involucrum, enclosing the sequester and infected tissues. If the infection persists, pus and thin sequestrated spicules of bone may be discharged through perforations in this area, and these perforations called cloaca in the involucrum, and tracked by sinuses to the skin surfaces by what's called cloaca or sinuses. And so in the involucrum, it is a piece of dead bone surrounded by living inflammatory tissues, like a bag of bone. If the infection controlled and intraosseous pressure released at any early stage, this process will stop. This is the site of the primary infections, spread to the periosteum and might spread and might be re-enter the bone, or might be spread here, and if it is this area intracapsular, it might burst to the side joint. And to the medulla, it extends to the medulla, causing intraosseous, increasing intramedullary pressures, and causing a cross of part of the bone here, and form a sequester, which may be large or small according to the extent of infections and the method of management. Resolution. This is the last stage of the inflammatory process or infection. The bone around the zone of infection become increasingly dense, and this is together with the periosteal reaction result in thickening of the bone. In some cases, the normal anatomy may be eventually reconstituted. In other, though healing is sound, the bone is left permanently deformed, so that the healing might be in a deformed posture of the bone. If the healing does not occur, a nidus of infection maybe remains locked inside the bone, causing a pus and sometimes bone debris to be discharged intermittently through the persistent sinus or several sinuses, and the infection has now lapsed into a chronic osteomyelitis, which may last for many years. Clinical features. The patient, usually a child over 4 years, presented with severe pain, malaise, and fever, and neglected cases toxemia may be marked. The patient will have noticed that he or she refused to use the limb in a form of pseudoparalysis, and you can't handle him or touch the infected part. And there may be a recent history of infection somewhere, like septic toe, boil, or UTI, sore throat, and so on. Typically, the child looks ill and feverish, and the pulse rate is likely to be over 100, and the temperature is raised, and the limb is held in acute tender near one of his large joints. Local redness, swelling, warm, and edema, and there are later signs. Edema usually later occurs. This is a classic picture of osteomyelitis, and Then we come to diagnose image. The patient usually is sent for X-ray during the first week of onset of the symptoms. Then X-ray shows no abnormality apart from displacement of the fat plane, signifies soft tissue swelling. But this could as well as occurs in the hematoma and soft tissue infections at the bone. By the 7 weeks, there may be a faint extracortical outline due to periosteal bone formation or periosteal reactions. This is the classic X-ray sign of early pyogenic osteoarthritis, but treatment should not be delayed while waiting for it to appear. Usually, it is earlier than this. Later on, the periosteal thickening becomes more obvious and there is a patchy rarefaction of all metaphyses. Ultrasound detects some periosteal collection of fluid in the early stage of osteomyelitis but cannot distinguish between hematoma and pus by ultrasound. Radioisotope scanning sometimes used, but it is so expensive and it is a difficult technique, but you can mention by using technetium 99 which reveals increased activity in both the peripheral face and bone face. This is the highly sensitive investigations even the very early stage of infections. And relatively low specificity and other inflammatory lesions can show similar changes. In doubt cases, scanning by gallium 65 can show or indium 111 labeled leukocyte may be more prevalent or revealing infections. MRI is also sensitive, but usually need in childhood need anesthesia, and this is difficult. Bone infection can be differentiated between soft tissue and bone infection by MRI. Here the X-rays, you see it, osteomyelitis, early, nothing specific. Then there is rarefactions, and here periosteal reactions. It is sometimes this is also confused with tumor, so that in any case with osteomyelitis usually sent for histopathology. This is bone scan, osteomyelitis increased uptake, you see it. Here there is site of rarefactions in the lower metaphysis, and here MRI, sagittal brain, and here there is rarefaction area of the infections. Lab tests including CBC, and we see usually leukocytosis, and also tissue aspiration might result in bacterial isolation by culture in about 60% of them, and blood culture are positive in less than half of the cases, and the C-reactive protein usually raised, elevated within 24 hours, and the ESR also within 48 hours after the onset of symptoms. But we use the CBR, C-reactive protein, as a prognostic test because it is raised up and go down with the improvement, while the ESR raised up and go down in the long time. The white PC count raised and the HB concentration may be diminished. Differential diagnosis. Here we have a lot of the differential of the diseases might be named acute osteomyelitis. First of all, cellulitis. There is a widespread superficial redness, lymphangitis, and MRI will help the distinction between them. But sometimes it's clinical diagnosis, and it's sometimes difficult to evaluate and read drainage in both of them. Acute suppurative arthritis, tenderness is diffuse and movement at the joint is completely abolished by muscle spasm. A progressive raise in a C-reactive protein within, and also ESR, also an aspiration of the pus from the joint suggestive of infections. Streptococcal necrotic myositis, group of the beta hemolytic streptococci invading the muscle and causing an acute myositis. Careful history, physical examination, and MRI can diagnose the case. Acute rheumatism, the pain is less severe and it is tended to flit from one joint to the other. And there may also be sign of carditis, rheumatic nodules, or erythema marginata. Sickle cell crisis, this patient may present you with features indistinguishable from those of dermatitis, and the areas where Salmonella is endemic. Treated with such patient with suitable antibiotic until infection is definitely excluded because it is susceptible for Salmonella osteomyelitis. Gaucher disease, pseudo-osteitis, but here there will be enlargement of the spleen and liver. How we treat this one? Cardinal feature of acute osteomyelitis: pain, fever, refuse to be alert, elevated white cell count, elevated SR, elevated CR. These are the classic features, and the complication of physical damage and altered bone growth, separative arthritis, metastatic infection, pathological fractures, chronic osteomyelitis. How we treat them? For osteomyelitis is suspected, on the clinical ground, blood and fluid sample should be sent for culture sensitivity test and starting early treatment by antibiotics without waiting. And there are 4 important aspects in management of patient: supportive management, pain and dehydrations, supplementage, and antimicrobial and surgical trench. These are the classic management of osteomyelitis. We must apply this protocol for every cases, and might be it is enough to give him antibiotic and 48 hours improvement. There is no need for surgical trench in certain cases. So we come to the chronic osteomyelitis. It is either a sequel of acute osteomyelitis or from other causes. The usual cause is the pre-existing acute osteomyelitis, open fractures or operations, and the usual organism, and with the time there is always a mixed infections. Staphylococcus, Escherichia coli, Streptococcus pyogenes, Proteus mirabilis, and Pseudomonas aeruginosa. In the presence of the foreign implant Staphylococcus epidermidis, which is normally non-pathogenic, is the commonest of all. Pathogenesis: acute hematologic osteomyelitis, if left untreated or not so properly treated, and provided the patient does not succumb to septicemia, will subside into a chronic bone infection, which is independently, perhaps with alteration of flare-up and spells of the apparent quiescence. And there is a history of long history, maybe 10 years, or flare-up of infection and quiescent period, and then flare-up and so on. Okay. There is notes. There is evidence that bacteria can survive inside osteoclast and be released when the cell dies. This is an important point. So the bacteria can survive inside the bone cell and release after, like these of tuberculosis. They survive inside the cell. Here, the bacteria can survive inside the bone cell, the osteoblast, and then release after death of these cells. Pathology: the bone is destroyed or devitalized either in discrete areas around the focus of infection or more diffusely along the surface of a foreign implant. Cavities containing pus and piece of the dead bone sequestra are surrounded by vascular tissues and beyond that by areas of sclerosis. The result of chronic reactions in new bone formation in fulcrum. Sequestra act as a substrate for bacterial adhesions in a much same way as a foreign implant, ensuring the persistence of infection until they are removed or discharged through the perforation in the fulcrum and sinuses that drain to the skin or to outside. The sinus may seal off and reopen somewhere elsewhere the tissue tension raise. Bone dissection and increasingly brittle sclerosis sometimes result in pathological fractures. But these are the pathology of chronic osteomyelitis when there is cavitation with the piece of the disrupted bone or necrotic bones, and there may be a formation of fulcrum and sinuses with discharging pus and piece of the bone and this flare up and quiescent period, and then maybe develop to pathological fracture where the area of the bone is weakened. Clinical features. The patient presented with a flare up of infection, pain, pyrexia, redness, and tenderness after quiescent periods, or it may be present with a discharging sinus, and there may be a seropurulent discharge and excoriation of the surrounding skin. These are the classic picture of chronic osteomyelitis. By imaging, the X-ray will usually show bone resorptions and thickening and sclerotic of the surrounding bone. And there may be no more than localized loss of localization, loss of trabeculation, or an area of osteoporosis, or periosteal an area of osteoporosis also. And sequestra shows up as unnaturally dense fragments. A sinogram may help to localize the site of infection. Radioisotope scan sensitive but not specific because it might give any area of the reuptake. CT scan and MRI are important in a plan for treatment of chronic osteomyelitis, not for diagnosis. Treatment. Here, investigations. Beside the X-ray, acute flare-up, we said for ESR, selected protein white cell level may be increased, and superficial swab sample may not reflect the real percentage infections because in the deeper tissues, sampling from the deep tissue is important. Here, a picture of chronic osteomyelitis, and there is an implant filled in broken metals with flare-up of infections and multiple sinuses. Here, you can see. Treatment. Starting by antibiotic choosing according to the culture acidity and also the ability of the penetration to the sclerotic bone. Example, fusidic acid, clindamycin, and cephalosporins. Antibiotics are administered for 4 to 6 weeks and extended for another 4 weeks if surgical clearance is failed. There are important points. First of all, prevent spread of infections and control acute flare-up. Local treatment. A sinus may be painless and need dressing simply to protect the clothing, and colostomy bath can be used to stop excoriation of the skin. You use the colostomy bath. You know it. This use in the colostomy surgery. Use this back and on the sinuses to collect this. This is pus and dirty materials. Operations with a form of debridement. At operation, all the infected soft tissues and dead or depitalized bone, as well as any infected implant, must be excised. After 3 or 4 days, the wound is inspected, and if there are any sign of dead tissues, we must debride it also. And repeat the debridement and the same protocol several times if necessary, with antibiotic cover is continued for at least 4 weeks after the last debridement. And sequestration of the cavity, or we do what's called socialization. That means make the boundaries of the cavity more stopped to get rid of any infections. And then dealing with the dead space by bone grafting or muscle flaps, and very rarely may need amputation of the infected limbs. Complication and acute exacerbation might be occurs, growth abnormalities, pathological fractures, joint stiffness, sinus tract malignancy, what's called margarine ulcers, which lead to the squamous cell carcinoma, and amyloidosis, which occurs sometimes, especially causing renal failure and chronic infections. This is chronic osteomyelitis. You see here, there is resorption of the bone, and here the sequestra, and here the cavity filled by a piece of the bone, and the muscle flaps vas laterals to cover the area. So that chronic osteomyelitis, it is a problem, and is highly costly and has been estimated for each case become chronic osteomyelitis. It may cost society about $1 million. So it is so expensive in its management and make that case out of the work. This is the last slide. And next lecture we complete the session of infections.